So going through some things that you may be dealing with your patients. In terms of generic medications and how they relate to epilepsy and other conditions, we're going to talk about what the FDA has set for standards. So when we talk about generic medications, there's a lot of misinformation and miscommunication. So I'm going to relate to you guys kind of what the standards are, what you guys are going to be seeing, and when people like me in the outpatient setting are filling prescriptions for your patients, kind of what their level of information is as well. We're going to talk about how that may affect patients, and I'm going to be able to give you guys some of the literature that's published on this to look at generic versus brand medication, primarily focusing on neurological conditions, but we're going to talk about a number of others, because what we'll see is there's really only one study in neurology related to pediatrics. And so we don't have a lot of information, so I'm going to try and go over that. And then talk about how we can best use the available literature, use the information we have, use whatever options you guys may have, because many of your patients are similar to those that I saw when I was down at Brigham and Women's and at Tufts Medical Center, where they're an indigent population, where we're not necessarily being able to target some of the high-cost, newer medications for all these patients. So a lot of misinformation exists, and you guys will know this. But this, what you'll see, kind of the screenshots were when I did a Google search of brand versus generic. You get a lot of information, and you get a lot of information that isn't necessarily from the most reliable of sources. Just doing a Google search, you can see that there's a link for the Mayo Clinic, but then there's also the medicinenet.com, which is a publicly funded website. And then you have others which are, Yahoo chat sites where people will give their own opinions. I had this with this generic, I had this with this brand. So, there's a lot of different information. And I think generally people understand that generics will cost less, but there is a lot of other misinformation about even how much less they have to cost, and really what sort of quality control measures are available or regulated for those. This is a table, and I love tables because I can put a lot of information and highlight a lot of information in a short period of time, and you don't have to necessarily discern through lots and lots of other pertinent things. So from this, what we can see from the FDA, the Food and Drug Administration, they have a lot of requirements, a number of requirements that must be met for both brand and generic drugs. Now, putting this information in a tabulated format doesn't do you guys any good if I sit here and read word for word on these slides. So what I want to really just summarize from this data is that the manufacturers are required to adhere to a lot of stringent criteria, both generic and brand. We also know that the FDA has not had a strong amount of oversight, and there's been problems from distribution from both brand and generic manufacturers, and that exists. Now, the requirements for a number of these are very similar between the two, and what you'll see is that there are some very strict adherences for reformulations of brand or generic drugs. The FDA has to review this information, so if something's going to change, they have to submit new information to the FDA. The FDA does review the labeling for this manufacturers, both brand and generic, and they control or approve kind of what goes out to the patients and to the pharmacies. And you can also see that adverse reactions and serious adverse health events for both brand and generics must be reported or are strongly encouraged to be reported to the FDA. Now, we know that there's selection bias. People don't always report some of these things, so we don't always collect a lot of this data. But the FDA does mandate that these things do happen. Now, that being said, there are dissimilarities between brand and generics. So this is kind of for you guys. True or false, and we can do this with a show of hands. Generic manufacturers are required to perform extensive drug trials similar to what they would for brands. So anyone for true? You would hope so. They don't. The answer is false. So brand name drug approval process has to go through phase 1 through phase 3 trials. And we can have a discussion on how extensive those trials really need to be. But there are trials that are required. Now, the data from those trials doesn't always go to the FDA. Sometimes they'll approve them with only a single study for brand name drugs. But at least there is drug information that's being viewed by the FDA. For generic drugs, which the FDA will call or term bioequivalent, they don't have the same level of rigor. They do not have phase 1 through 3 studies. What they do are pharmacokinetic studies. I'm counting there's about 20 of us in this room. We could, in theory, make up a cohort of patients for a bioequivalency study based on our number here. Generally, those are somewhere between 20 to 100 subjects, and they're given single-dose crossover studies. So they're given a dose of the brand, they're given a dose of the generic, they may give them several doses if there's multiple doses available, and they draw blood. And they look and see how accurate or how much of the drug is available in your body over a period of time for the brand, and how does that compare to the generic. They measure early onset, total onset, and peak onset of the drug in terms of concentrations. And if it falls within their standards for purity, which we'll talk about, the drug receives approval. Now, the drug approval process looks at the active ingredient and compares that for different strengths or different dosage forms. So if you have a drug that has multiple dosage forms, let's say a 50 milligram, 100 milligram, and a 200 milligram, they may only actually have to produce results for one of those. And what they can do is they can extrapolate that data out for others. And we've seen problems with that, and I'll mention a couple of those as that relates to some neurological drugs specifically. So they're not performing human studies in the same sense that they are for brand name products or generic manufacturers. They're doing blood samples to look at how much a drug gets exposed over a period of time. So this is another multiple choice question. So the FDA sets which standards for bioequivalence of generic products. So the generic or bioequivalent product has to be between 50 and 150% of the brand name product, 80 to 125%, or 90 to 105%. So how many for A?
I would say.
Okay. Okay. So use takers. How about for B? 80 to 125, and how about for 95 to 105? So we have one brave soul in the back. So B, unfortunately, is the, well, I guess A fortunately is not the answer. B, unfortunately, is the answer. And C is what the FDA is hoping to go towards. So currently you can see that bioequivalence is set by the FDA if the concentrations range between 80 and 125% for a generic manufacturer. There is current legislation, as we know, there's a lot of current legislation for a lot of things, to try and push this even more stringently to 95 to 105%. But currently we have that 80 to 125% window. So this means that bioequivalence generics are not exact copies of the brand, and I think you guys already know that. The rate and extent of absorption must be equal, but it doesn't mean the actual milligram strength of the tablet has to be the same, or the capsule has to be the same. You are given a window, 80 to 125%. So there is a potential for up to a 45% difference from manufacturer to manufacturer of a generic product. You could have some that are at 80%, you could have some that are 125%, and you have the brand name product that's considered the equivalent, or the gold standard at 100% in the middle. Now, there is a lot of literature looking at this, and we'll go over that, but currently we do know that the FDA will allow kind of this up to a 45% window. And that can be very, very troublesome, especially for patients who need these narrow therapeutic window drugs, where we're doing a lot of blood monitoring for them. Some drugs it may not matter, but some it could very much matter. So what has the FDA done? What do we know about this? We'll talk about that. But this is another point from the generic manufacturers. Active and inactive products are the same between brand and generic products. Many of you are shaking your head no, saying false. That's true. You are correct, I should say. The active and inactive ingredients must be proportionate in a generic manufacturer. So a 50 milligram tablet must contain twice as much of the inactive ingredient as the 25 milligram. But the inactive agents can vary completely. They don't have to be the same at all. So how does this also complicate things? You can have differing dyes, so patients with food allergy dyes. There is, other manufacturers who will put things like aspartame and other additives into products that can cause patients to react differently than they would from the brand name. So not only are we dealing with the generic manufactured drugs that may not necessarily be equivalent in terms of the milligram strength, but we also have additional fillers or excipient ingredients that can be different. So this really leads to the fact that, that we can have patients who are taking drugs that may be bioequivalent, but may be vastly different in their makeup and their composition. So the question that comes up, knowing these differences, is are generics really the same? And the answer is no, we have to say that they're not the same. But how close are they? Without going through a lot of the data, what we can see that over about a little over a decade period of time, for about 12 years, the FDA gathered data on bioequivalent studies and published this in 2009. And what they found is that looking at almost a little over 2,000 studies of bioequivalence, that the generic product was almost identical to the brand product. So you can see the maximum rate of absorption, that's the Cmax, the concentration that was absorbed, the maximum amount of the drug was at 1.0 with 6% variability. The AUC, which is the area under the curve, how much drug gets absorbed system-wide over a period of time, was also at 1.0 with a 4% difference. So of those 2,000, 2,100 studies, we can see that the average difference between all the products that were approved over that 12-year period of time was between 4.5% and 3.5% between the total maximum amount of drug and the amount of concentration of the drug that was absorbed. More than 98%, or approximately 98.2% of all those drugs that were studied, there was less than 10% variability. So although the FDA allows that large window that we talked about, that 80 to 125%, the reality is of the generics that have been put on the market, over 2,700 or over 2,000 studies, most of them were at or within a small percentage, 2 to 4% of the brand name product. So that is encouraging. Now that doesn't mean that, that's necessarily true for every single product, and we have examples of that, and I'll highlight some of those. But in general, most products are going to fall within 3 to 5% of the actual branded product. To further complicate matters, and you guys may be dealing with this, some generic products are produced by the brand name companies. I don't know if you guys are aware of this. So sometimes, and currently there's legislation to kind of look at this, but the brand name product can be sold under a generic manufacturer and they will facilitate the distribution of that product. So one drug comes out, in this case Concerta from the manufacturer, and another one comes out with methylphenidate ER. They're the same drug. They're put in two separate bottles and they go to different retailers and they're sold at different prices.
Is it usually when the patent is ended on the drug?
Sometimes, but not always. Sometimes they will strike agreements, and that's kind of what's being looked at right now is how are these agreements coming forward. But typically what will happen is a company will be given exclusivity to market the generic. What the brand name company will tell them is, don't worry about filing all the paperwork. We'll demonstrate that all the paperwork on our end. You guys will pay us for the distribution of the product and we'll split the profit. So currently with Concerta and Lipitor, those are the two most recent products. The manufacturer of the brand, Pfizer, who's producing both of these, is paying a generic manufacturer to distribute its product. It's the exact same product. When I or my colleagues, I don't do much of this, but when I'm working in a retail pharmacy, a community pharmacy dispensing these drugs, they're the exact same. The imprints are the same. The look is the same. They are the exact same tablets. You pull out a brand and a generic tablet. I close my hand, tell you which bottle it came out of. You can't tell because they are the same drug.
But that's good.
It's good, but it holds up the prices. So how much less expensively, and I don't have this in the slide, does a generic manufacturer have to market a generic drug than a brand? Does anyone know? There is an actual dollar figure.
Number.
Anyone want to guess?
Do you have any 5%?
1 penny less.
Wow. And that actually exists as a rule?
It has to be 1 cent less than the branded drug. So we have generic drugs that are still vastly overpriced. For instance, generic Augmentin, I don't know if any of you guys have ever had a patient who needed that for URI or whatever it may be. A 10-day course of generic Augmentin is made by only 1 or 2 manufacturers and it's still over $100. It's still vastly expensive. So for patients who don't have insurance, it's much more cost ineffective sometimes than it are for patients who have health insurance will provide generic coverage. And some of that gets down to the fact that the branded product is being sold as a generic through a licensing agreement. Drug prices, especially for generics, don't tend to drop until the drug has been on the market as a generic for at least a year, if not more. And sometimes it's even longer than that. So perfect time, questions. I told you I have a lot of these, 4 of them, so I have places to stop.
Is there a way that we would know? Because
Whether or not a generic is a brand name product is being sold as a generic?
Yeah.
Probably not. I mean, you could always call.
Yeah.
The people who dispense the drug would have a better sense, but that's not going to get communicated widely.
Yeah.
There are things that are rejected by the insurance company, and so you go looking for something that the insurance company will pay for. What happens if it's the same person thing?
And we'll talk about that. But
All
there
the
are
hoops to jump through.
but there are instances where and we'll talk about these, New Hampshire Medicaid and others, where they will strike a deal with the manufacturer where they actually prefer the brand name product over the generic, which doesn't make sense. Because they will authorize reimbursements, or Pfizer, or I don't want to pick on Pfizer, but GlaxoSmithKline or any of the drug manufacturers will say, we'll give you a rebate.
Yeah.
Got it.
So they pay money back to the insurer and say, we'll give you a rebate on the brand name product. In the case of Lipitor was less expensive than Simvastatin for a period of time for most insurance patients, most insured patients, because Pfizer was paying back to the drug companies. To let them know that there was they were giving them rebates on the drugs.
Good Lord.
Yeah.
Is rebate the same thing as a kickback?
That's a fancy name for it.
Yeah.
It's a more
legal name.
More legal name,
It's sketchy, doesn't it?
Politically.
It sounds sketchy.
Yeah.
it is sketchy, and there is legislation looking at this, but drug manufacturing lobbies are huge.
Yeah.
Ridiculously huge.
Other questions, thoughts? I'm just delivering the information.
We
Don't
know.
throw names at me.
No, exactly.
So we know that the FDA allows a wide level of range between the manufactured drugs for brand and generic, but also we have some evidence, some pretty compelling evidence, that most of these products are very similar. So what does the actual literature say? There's not a lot. And we're going to go through what literature does exist, but I'm going to talk about something that's outside the scope of this topic first, because this is where most of the literature lies in terms of generic manufacturers, is looking at ACE inhibitors, or looking at cardiovascular drugs. So ACE inhibitors, alpha blockers, antiplatelet agents, beta blockers, statins. A meta-analysis that was published by some colleagues down at the Brigham and Women's Hospital in 2008 looked at about 25 studies. And of those studies, which looked at several thousand patients, there was almost a 100% equivalence in outcomes, measurable outcomes, largely related by blood pressure, heart rate control, systolic blood pressure, EKG changes, and new onset of cardiovascular death and events with those agents listed there. Almost 91% equivalence with diuretics, and a little less with calcium channel blockers. So from this, a lot of data was coming forward saying that for a lot of conditions, primarily heart-related conditions, hypertension, that we can interchange these drugs safely, and there isn't a lot of downside to doing that. And so a lot of people were much more comfortable doing that. Another review in 2003 demonstrated very similar results. So within the cardiac literature, there's a number of evidence published that shows that these are completely bioequivalent and that people interchange them. Now, one thing that we can see from this is these are measurable outcomes, and we'll talk about how that may differ for other conditions, especially when we talk about epilepsy. You can't necessarily measure someone's blood pressure. You're not going to do serial EEGs on these patients to see how their control is. So these have very measurable outcomes that you can bring a patient back and you can check. Some other conditions don't always have that same level of ability to measure. So what generic data exists for central nervous agents? We know that looking at data that's published coming out of the government, that central nervous agents as a class are the largest growing segment for generic utilization, and a lot of these drugs are falling off of patents. We know that from the data looked at, they save $250 billion over a 10-year period by the use of generic medications, and that savings is based on the cost for brand new drugs. We also know that many of these meet FDA standards, but you guys may have experienced this here for Bupropion XL. I don't know if you guys were familiar if this is a drug product you guys use, but there was some reports that came out at the end of 2012 showing that the extrapolated pharmacokinetic data was wrong, and that those patients who were taking set doses of Bupropion XL, 150, 300 milligrams, actually were not receiving anywhere near the marketed dose. And so there was a whole host of patients who were having relapses and failures, treatment failures with generic Wellbutrin XL when they were switched over, because the data that was submitted wasn't submitted properly. It wasn't properly vetted data, and it was incorrect data. And so there's been a massive recall from certain lots of manufacturers who have produced Wellbutrin XL. And those are issues, and those are small, but when they happen, they can have very devastating effects. I mean, someone's lack of control or a relapse of depression can have very, as you guys know, I'm not going to tell you, but very severe outcomes in the worst case scenarios. And this is something that we see, that even with these kind of controls that we have in place, not everything is always as it would seem, or you would like it to be. Again, I am a pharmacist by training. I am not I'm not a diagnostician, so I'm just going to comment on generally two guidelines. The most recently updated neurology guidelines that came out of the New England NICE group in 2012 in January. And so depending on the seizure type, these are what their recommendations are. And I also have the most recent American Association of Neurology kind of updates on how they manage these patients. The reason I mention this is if you look through all of these, there isn't a single category where the first-line drug product is a brand name product. All of them are generic. And I'm highlighting that because when you're treating these patients, you're going to be most likely prescribing a drug in many cases where a generic is either available and or is preferred based on their health insurance. And very few of these products even have branded only status anymore. So most of these patients, when they go to a pharmacy or one of my colleagues may be filling their prescriptions, unless there's stringent kind of restrictions based on your prescribing patterns or their ability to get branded products through the insurance, they're going to be interchanged to a generic unless you specify otherwise. And we'll talk about kind of what you need to do to ensure that. Now, looking at the 2004 AAN guidelines, when these were written, oxcarbazepine, trilethol, was a brand name product. Topiramate, Topamax was a brand name product. Lamotrigine, Lamictal is a brand name product. That has all since changed. Each one of these drugs in the last 1 to 2 years has become generically available. So where they were demonstrating equivalency in their guideline recommendations to some of the older generic antiepileptics, those have all since gone generic. And so for most of your patients, if they're not on a generic product already, they may very well be, especially when we talk about some of the future products where you may be using them, especially for certain neurologic conditions. So what data exists? We talked a little bit about the cardiac literature, but that's not really pertinent to this talk today. So when we look at studies related to neurologic conditions, we have anticonvulsants, antipsychotics, and antidepressants. That's where the three big classes of data come from. Anticonvulsants, there's 17 total studies published ranging back from the 1970s through 2012. Antipsychotics, there's 14 studies, and antidepressants, there's 1.
Wow.
Now, when you break down the 17, which I've done, you can see that 17 of these, of them, a majority, 2/3 of them were retrospective, so we have very little prospective studies that give us a lot of great data. When we look at a number of them, they evaluated only one product. And of those, most of them were either carbamazepine, lamotrigine, or phenytoin, with almost 90% being carbamazepine and phenytoin. So drug products that may not necessarily be on your first line prescribing for some patients, but might be a potential consideration for certain patient populations. We essentially have no data for what our neurology department at the Leahy uses almost first line for every patient, the generic Keppra and the levetiracetam. So we don't really have any sort of data to look at how that product relates to the brand name at all. Valproic acid, so the Depakote products, we don't have any. We have one study that looks at that, and it's a very small study. So what we have is essentially, I don't want to use this term if this is a drug product you guys are using, but older drugs that have more side effects than we have, that's the ones we have the most data from. Now, there's still a role for carbamazepine, still a role for phenytoin in some patient populations, but the newer agents that we see that you guys may be defaulting to because they have less side effects, maybe more tolerable, we have almost no data for. We'll talk about what data does exist, and I have that on a table in the next couple of slides. When we talk about antipsychotics, which maybe some patients you're evaluated and using for, 98%, all but one study looked at clozapine. So we don't have a lot of good data on almost any other antipsychotic agent, knowing that there are 3 new agents that are relatively new agents in Zyprexa, Seroquel, and Risperdal, which are all generically available now, a couple more forthcoming. We have no data on those at all. Those might be your default products, again, based on side effects, based on monitoring. We have no data. On all the antidepressants that are available, almost all of them are generic. There's one study that evaluated fluoxetine. We'll talk about that. So we don't have a lot of good data, and that's unfortunately what I'm here to try and tell you is the data that we do have, we'll talk about, but there isn't an extensive amount. So generic anticonvulsants, I broke this down to the 3 big drugs that were studied. Now when we look at carbamazepine, 5 out of 6 of the studies showed no difference in seizure activity. There was a study, and I have this data broken out on the next slide, that showed 2 out of 20 subjects had increased seizure activity, and in the brand name group, and 4 out of 20 had it in the generic. So what do we take from this? Well, in the generic, they had twice as many patients had seizures, but it's a very small sample size. And it was a very short period of time. It was over a 6-month period of time. In the other studies where we have more data, they showed no difference in new onset seizure activity. When we look at lamotrigine, 2/3 showed that there were higher doses of generic products required. So that gets to some of that bioequivalence potential where they may not necessarily do one-to-one interchanges. You may have a patient who's stable on 100 milligrams twice a day of lamotrigine, but on the generic, they may need 125 milligrams or an increased dose. One of the 3 studies which looked at overall outcomes showed no increase in emergency department visits, hospitalizations, or change in additional adjunctive therapy. So we do have some positive data regarding lamotrigine. And with phenytoin, the 3 studies that are published showed no difference in seizure activity. So the data that is out there shows that most patients have reasonable control. There are some anomalies to that, but again, looking at the total amount of data, it's not a large patient population size.
Can I just ask a question? I
Yeah.
assume for this study design, the generic that was used was the same generic formulation?
We'll talk about that, and it's not.
It was not.
They don't. Most of these are retrospective studies that mine pharmacy data, and we'll look at that, but they're not always the same generic. Most of the time they are, but not always. So you can see here, I've highlighted in the center the one pediatric study. So of all the literature that we've talked about from the carbamazepine, all 6 studies, which again isn't that much, only one of them was a pediatric study. If you look at these, no one study had more than 50 subjects. So we're talking very, very small samples. 23 pediatric patients was a randomized crossover control study. So it was kind of the best study that we could hope for. There was no difference in some concentrations of the drug levels for these patients. They did use a formulated single brand and single generic in that study. The other ones that were prospective used single-dose studies, but not always in the case for some of the others. And in that study with pediatric patients, again, they were looking at very small numbers. They didn't show over about a 12-month period of time any difference in frequency or adverse effects of seizure control or in concentration. But again, looking at this, if you total all these up, we're talking just under 170 subjects. So we're not talking large patient data numbers here. So you can see here, I've highlighted in the center the one pediatric study. So of all the literature that we've talked about from the carbamazepine, all 6 studies, which again isn't that much, only one of them was a pediatric study. If you look at these, no one study had more than 50 subjects. So we're talking very, very small samples. 23 pediatric patients was a randomized crossover control study. So it was kind of the best study that we could hope for. There was no difference in concentrations of the drug levels for these patients. They did use a formulated single brand and single generic in that study. The other ones that were prospective used single-dose studies, but not always in the case for some of the others. And in that study with pediatric patients, again, they were looking at very small numbers. They didn't show over about a 12-month period of time any difference in frequency or adverse effects of seizure control or in concentration. But again, looking at this, if you total all these up, we're talking just under 170 subjects. So we're not talking large patient data numbers here. So this study looking at the largest number of patients we have over the longest period of time with relatively stable patients using no more than 2 generic products. What we can see is that there were statistically significant increased rates of either epilepsy-related hospitalization, length of stay once they were hospitalized, or their requirement for outpatient services. Now, while they are statistically significant, we have to look at the actual events. So for patients who were hospitalized, over that 4-year period, it went from 0.14 to 0.18 when using a generic product. So there was an increase, but over the course of a year, that really related to 1 in 4 patients had an increased hospitalization. So it's not necessarily a huge increase, but it was a statistically significant increase. When we talk about length of hospital stay, we were just under 1 day for brand name products, just over a day and a quarter for generic patients. Again, it was a 29% increase, but it'll be up to you guys to determine, how, really what's that quarter day. I mean, there is a cost associated with it, but what's the actual data? Does that really impact how I would prescribe? When we look at outpatient services, and these are outpatient services geared for specifically epilepsy control-related issues where they had to be seen as opposed to their scheduled visits. 2.5 visits per year versus almost 3 visits a year, so there was an increase. So what do you guys want to do with this data? I mean, this is what the data is. We know that over a 4-year period of time, looking at the largest number of subjects, there were statistically significant increases in hospitalization, length of stay, and the utilization of outpatient services. While they are statistically significant, we would have to decide in with the appropriate context how significant are those increases. I can't really tell you guys. I can tell you what my interpretation is. I mean, there is increases in length of stay. There are increases of outpatient services and epilepsy-related hospitalization. I don't know. Related to the hospitalization, 0.14 versus 0.18, I don't see that as being a very measurable difference. I would say the generic utilization as it relates to hospitalization essentially was almost no different, even though there was a net 24% increase. When you look at the raw numbers, they're a little bit different. Length of hospital stay, a quarter of a day, a third of a day. I mean, that could, in fact, if you have that over 30,000 patients, be a very substantial amount of money that gets paid to the healthcare system for those patients' care. Same thing for outpatient services. So there is data that shows that even though the raw numbers are higher, when we look at the actual numbers, they may be a little bit different, but there are increases. And I think that's important to know, that the use of generic medications in this large study did demonstrate increases across the board.
What's interesting about that is that you present it to us as though it's our choice to be able to make that decision, and really what becomes the only choice you have is dependent upon what insurance companies made it. And I don't know, I would love to think they're looking at this data too, but I kind of doubt it. It depends on who's the best negotiator at the table as far as who's going to give them the rebate or whatever
that's
else.
also true.
It's going to happen. It's very frustrating.
What is the cost difference of the medication of the generic versus?
Yeah, and that wasn't a calculation that was factored into this in terms of cost differences to the health system relative to any one of these as a total, which would have been an interesting outcome to look at.
And what about loss of productivity?
Yeah, that's another thing that, both the direct, indirect costs associated with this. If you're in the hospital an extra day, well, that probably means you've lost a second day of work, potentially more. Or you've had to go to the outpatient visit an extra half a day, so you've had to take off additional days from work. And those are things, unfortunately, that weren't included in part of the study.
I would say, having worked for insurance in the past, that they do look at stuff like this. I don't know what they do with it.
Yeah.
But they don't
That's
look
At
at
least
your
look at
hospital
it, yeah.
studies.
No, of course.
And the logical thing for all of us would be to say, well, then they should look at the way generics are covered in a different way. I don't know that, do you know, maybe that might be in the works or something?
I do have some stuff from insurers and some people that I know that work in the Medicaid offices who do kind of claims adjudication on the pharmacy side of things, so people who you submit your PAs to, and they've given me some inside information. It doesn't look good though. And I'll preface that it's probably going to get more stringent in terms of generic utilization based on what I'm hearing from them. So we can talk about that, but I don't have a lot of inside information on how they make assignments relative to that. Yeah.
Oh, I have a question. With the generics that are available in this country versus people who get their medications from Canada, is it the same drugs that are getting from Canada? Or different ones?
Depends. Most of the generic manufacturers are based either in the United States or outside. There aren't any generic manufacturers in Canada specifically, so they either import them from the United States or they, like us, will import them from other areas of Europe or India, so another
So
hot
basically
place.
it's the same.
They're getting the same
generic.
drugs. The cost difference because of the way that their health system puts caps on what they can charge. So generally, they are the same drug.
Was there anything in the study design that sort of weeded out individuals who might have been stable on brand name medication for either shorter or longer periods of time? So you could determine, that this average hospital stay really is related to people who had predominantly been stable, or this is their first medication uses versus someone who hadn't been particularly stable in the past.
So they looked at patients who had been on a stable dose of a particular product, either the brand or the generic, for 3 months at a minimum. So if they didn't fit that criteria, they were excluded from their data collection. So these weren't people who were being switched kind of midstream. There are some who do that. But these were patients who had been stable for at least 3 months on a set dose based on the pharmacy records. Now, there's a lot of problems with that because you could have people who are filling things that they're not necessarily taking. They had no ability to kind of look at some of those
3 months isn't
individual
really
levels.
that long.
No. And so they looked at kind of just the data that they were able to get from the insurance and the pharmacy data. They weren't actually intervening and seeing each of these patients. So even then, in this large study with multiple patients, it's still not the most ideal. It was a retrospective analysis of these patients. And there's a lot of ability to kind of confound that data, unfortunately. And that's what I'll say in the summary is we have a lot of data in some cases, but we don't have a lot of good answers still.
So this was only 3 months?
No, this was over 4 years period of time.
Oh.
The data collection was done over 4 years,
Oh,
but it was
okay.
taken from insurance company data.
Oh.
So they never actually, the patients weren't coming in to be seen.
Yeah.
They were going into their own providers, and when they had a visit, it was flagged by an ICD-9 code or a DRG code that the insurance company they were able to take a look at that.
Got it.
So moving away from the anti-epileptics into the antipsychotics, knowing that 13 of the 14 studies are looking at clozapine, there's approximately about 1,000 subjects. And in the 2 largest studies that looked at this, they showed no difference in terms of their global impression scores or worsening of symptoms relative to relapse rates. And so what you can see kind of between these, and a small study showed a difference favoring the brand relative to their CGI and BPRS scores. But again, this is looking at clozapine. This is a drug that we're not primarily using for most of these patients, so we don't have a lot of good data for the newest antipsychotic agents and how they may work. We have a significant amount of data looking at older drug, clozapine, but if that's not something that you're normally using, how do you apply this data to the new agents, the Zyprexa, the Risperdal, and the Seroquel? I have no way to do that. Looking at generic antidepressants, one study looking at 40 subjects with fluoxetine showed that over the short term, the 3-month period of time, lower efficacy rates were seen with the generic, but at 6 months they were the same. There was no difference. But we also know that there's about 120 case reports that are published in the literature, not necessarily in a systematic fashion, that have shown a variety of agents that have shown worsening or reemergence of depression. And those are across agents, primarily looking at bupropion, as we've heard from the bupropion XL, but also looking at some of the newer agents like citalopram. So while there may not be a lot of published literature in a systematic fashion, we are getting case reports that say when patients switch from one brand to their generic, especially as it relates to antidepressants, they may have worsening in that. Now, this doesn't look at patients who were started on a generic and kind of titrated up. So that also, confounds things. If you were to start a patient on a new generic and titrate them up, would you see the same results? We don't know. Now, as I said, only one of those studies related to carbamazepine was done in adult or done in pediatric patients. And knowing that that's primarily who you're servicing, I'm going to talk about some other studies, but these may not necessarily be all of your patient population. This may be a small subset, but this is really all the data we have. There's 4 studies looking at the pediatrics relative to branded generic. We know from 2008 that in general, pediatric patients used much lower rates of generics than their adult counterparts. And that largely is because of indication, where most of the brand name products had to seek indication, and most of those are newer agents where they have newer indications. So in general, children predominantly, as of about 5 years ago, were using less generics than adults. But for those data that we do have, looking at hypothyroidism, the patients actually had better control using a generic levothyroxine product than those who were on a brand name product. So that also confounds some of this. You wouldn't think that was the case.
Right.
Looking at, again, a very small subject of 4 patients looking at post-renal transplant with the use of generic tacrolimus. 3 children had no difference, and 1 had acute rejection. So what do we do with that data? Was it related to the generic? Was it not related to the generic? It's 4 patients. We just don't know. And then looking at the HIV population, this is coming out of India, looking at about 65 children. They found no difference in CD4 cell count, tolerability, or adverse effects using generic antiretrovirals as opposed to brand name products. So this is the sum total of pediatric literature. You're talking about 100 patients for branded generic.
Now in this, publications, is the child on the same generic?
These are also patients. The prospective study, they were on the same generics. The renal transplant and the hypothyroidism, the renal transplant, they were patients who were given the generic in the hospital, so they were on the same from the hospital. And in the hypothyroidism study, they were looking at a drug formulated or a manufacturer formulated generic. So this does not mirror real life situation where a patient could go to CVS one day, go to Rite Aid up the street and get 2 different manufacturers because they use 2 different ordering warehouses. So you have patients that go to Rite Aid who use one ordering system. You have a patient who goes to Walgreens, they use a similar or a different, and then you go to CVS, whatever it may be, and they have different ordering systems. They can have different manufacturers. You can go to the same you can go to the same drugstore, and within once a month they can have different generic manufacturers because they purchase whatever costs the least amount of money from their buyers. So these don't mirror real world, real world life at all. These are the ideal situations if you have to have a generic or a brand in many cases.
So these are what the insurance companies are looking at?
They are, but I don't know what they're doing. Again, as Jude said, I don't know what they're doing with the data. I can tell you what their restrictions are, and we're going to talk about that. But this is the summary. Most of this is very limited in its ability to determine a cause and effect with the generic or brand. Most of these that are randomized or blinded have single sample sizes or single drug products where they're using a consistent version. They're not really mirroring kind of what we see every day. And when the real life setting, so when we talk about the fluoxetine, citalopram, bupropion reporting, those actually mirror most of what you would see as kind of a day-to-day practice, those case reports, because people say after having switched to multiple generics, I experienced this adverse effect. But in these drug trials, many of them are using a single product, a single brand, and a single generic, which may or may not be the case for most of your patients. Questions before we jump into kind of the insurer and provider perspectives on things?
I don't know if you'll address it or.
I don't know until you ask me.
What?
I will if you ask me.
What can be done to fix this? I'm always let's fix it.
The honest answer is probably very little.
Really?
You can encourage patients to use a consistent pharmacy, but even that doesn't necessarily get to the problem because pharmacies can interchange their generic manufacturers from month to month or months, 2 months, or year to year. That happens less. That variability tends to happen less if you stick with one consistent either chain or one consistent system because generally people in those systems, they get the same amount of drugs from the same ordering supplies. You can also encourage patients, if at all possible, some pharmacies will be able to order different manufacturers. If you have a patient on a stable manufacturer, you can ask them to do that. That is something that you can make requests. I can't always guarantee that would be honored, but sometimes patients will say, oh, well, I'm on the TIVA to pick a generic manufacturer. I'm on the TIVA manufacturer. Can you guys order that? Is that something you're going to have? And most times they can do that, and most places will, but you may not know what your patient is getting until they're bringing in their pill bottles and it says marked somewhere on there.
But what about like the pharmacy level, I mean, the pharmaceutical level, you know, as far as manufacturing them so that they're closer? You know, so they fix that problem.
So with the exception of the FDA kind of tightening up those stringent guidelines and making it 95 to 105%, they're probably realistically not going to do much in terms of changing their practices because they don't have to right now. They just have to comply with what the FDA says. And they look at themselves compared to the branded product. They don't look at themselves compared to all the other generic manufacturers. That's up to the FDA to make that decision. So it really, unfortunately, lies with the FDA at this point. And that recommendation to tighten to the 95 to 105% level has been in the FDA's kind of decision-making process for a couple of years now, and they haven't acted on it. So ultimately, they're the ones who kind of regulate what the generic manufacturers have to or don't have to do, and the individual manufacturers. I mean, there's far more horror stories. I mean, Ranbaxy, I don't know if you guys have followed that, has had its generic manufacturing license taken away for about 8 months for substandard manufacturing processes. They weren't allowed to distribute drugs, and they distributed to the United States in large numbers. So, I mean, the generic manufacturers are not necessarily in any rush, from my perspective, to make changes unless they have to, unfortunately.
Can you say why the 3 drugs for anticonvulsants were studied and not others?
Largely because those were the 3 primary drugs when those drug studies were published. So most of them were in the late 80s to the early 90s, and that's why those were selected. They haven't done anything with some of like the newer agents like levetiracetam and some of the others. They just haven't had, they haven't studied them, and largely it comes down to money. Who's going to pay for the generic manufacturer to be made and included as part of the study drug? Because most generic manufacturers, unfortunately, only have to comply with the FDA. They're not necessarily in any hurry to show that their generic is less effective than the brand, because then you wouldn't use it. So most generic manufacturers have no vested interest in showing that they're worse than the brand or better than the brand. Because if they comply with the FDA, then they can say, well, we're bioequivalent. We should have the same results. But if you actually perform a study and show that they're not, then no one's going to use their product and they're going to lose out on hundreds of millions of dollars. That's another major limiting factor.
Do you know what the difference is across the board between generic and brand names? I mean, you said you only had to be a penny cheaper.
Yeah. Again, it really does depend on how long they've been out. Generally, you're talking a discount of somewhere between 25 to 50%. Generally.
But if we say brand name only, will that be honored?
We'll talk about what you can do if you really feel strongly, and kind of what New Hampshire insurers say, especially New Hampshire
Especially
Medicaid. I
Medicaid.
assume Medicaid was primarily where you guys
Yeah.
have your patients. So I have some friends who give me inside information. You're not going to like it. You're not going to find it published anywhere, but this is what they're telling me for that. But we will talk about that. Yes?
I'm wondering if the $5 deals that Walmart has and Walgreens and those, are they using lower quality of generics that might be less expensive, allowing them to do this?
The quality should not be questioned when they're doing that. It's really the availability of the drug to be obtained at a lesser cost. And so what you may actually see if you really dig into some of those is they're either old generics, which have been on the market for a long period of time, or they're single availability products. And not every generic is on those lists. So if you have older drugs, let's say, I'm trying to think what would be most applicable for an example. So for those programs, for generic statins, just to use this as an example, you're not going to find atorvastatin, you're not going to find generally simvastatin on those. You're going to find lovastatin and pravastatin. And why? Because those are less expensive, because simvastatin and atorvastatin are more newer generics, which command a higher price. So they're going to go for the cheaper of the statins, price-wise. Doesn't mean they're different in efficacy or safety or tolerability. It just means that they're manufactured and available for a lot longer and they're less expensive. You'll not necessarily see the same type of agents for anti-diabetic agents. You're not going to see, you'll find metformin because metformin is kind of ubiquitous and less expensive, but you're not going to find generic, let's say Actos, which is available, pioglitazone, because even though you may not want to be using that for a number of reasons, it's still an expensive generic. You'll find generic amoxicillin, but you won't find generic Augmentin, because amoxicillin is cheap, Augmentin is not, even as a generic. So the standards are the same, it's just what they can obtain the drug for at its cost. So providers and patients perceive generic medications similarly in terms of efficacy and adverse effects. True or false?
False.
False. Some very convicted falses. Okay. Largest I've heard yet. Lunch is eaten. Good. So if you look at neurology literature, again, this is sample size of about 300 neurologists. 2/3 reported breakthrough seizures and about half reported adverse effects. A similar study administered to about 4 times as many patients, 11 reported increased seizure activity percent and 70% reported no adverse effects. So patients and providers don't necessarily perceive these as the same. And these are similar patients looking at the same conditions. Looking at a survey of about 2,000 physicians, about a third reported prescribing brand name drugs when generics exist at a patient's request. So you guys may be faced with these patients as well. There may be a generic that they want a brand for whatever the reason may be, even though generics may exist. And then also relative to this, you have the 2007 American Academy of Neurology position statement, which directly abuts with most insurance companies relative to the use of anti-neuroleptic agents and a number of others, where they say providers should control the generic utilization and not the insurance company, which they want control of who can and who can't be on generics, and the insurance companies say, no, if there's a generic available, we're going to default to that. So we're going to talk a little bit about that. But from this, we can see that generally there is disagreement. And it doesn't really help us because we don't have a united front. We don't have literature, physicians, patients, providers all saying the same thing. So the last question. Insurance providers automatically and preferentially, when you see those two words, you automatically know it's false, right? Prefer generic medications over the brand name. So they always prefer generics. Of course, is the intuitive answer, not the case.
No, the brand name.
Yeah, generics are typically preferred, and I put that in quotes. But they may not prefer all generics equally. So for example, as many of you probably see, New Hampshire Medicaid excludes generic Lexapro and generic Zyprexa. They prefer other agents in those classes. So just because they're generic doesn't mean you can write it for your patient and have it approved. They may prefer a brand, and you guys may also be seeing this, where brand name Adderall XR is preferred on New Hampshire Medicaid, but not the generic. And why is that? Kickbacks. I should have said that. Rebates. They're getting a rebate from the brand name manufacturer. Shire is paying that to the insurance company, and they prefer the brand name product.
That goes to the general fund.
Yeah. The generic for Adderall XR has been out for about a year, and they still prefer the brand name product for those patients. So what does that mean? There's a higher drug cost to the system, but they get a rebate. Now, do your patients get a rebate on their copay? No. Can your patients, does the pharmacy get a rebate on the price of the brand name product?
Of course not.
No. And do you guys get anything in terms of a beneficial agreement for that as well? No. But you also confound things because you don't know if you're writing for a brand name Adderall XR, but you can have a patient who's on Concerta because they need more of that 50-50 control rather than 70-30 with Adderall XR. But brand name Concerta is not covered, so you have to kind of constantly be aware of this. They may also have restrictions, as you guys know, step therapy, age diagnosis, or quantity restrictions that hit up as well. So even though they may prefer a generic, they may not prefer it for every patient all the time, always. There's no good way to know that. You can go to their very cumbersome websites.
The only way to know that is to prescribe it, and then
And
you
see
get
what-
your
and see what happens.
prior authorization
Which is
request
horrible.
comes in the mail, or
Yeah.
gets faxed to. Then you start the fight.
Yes, yes, you do. I know it from both sides.
sure.
So we can't say generics are ubiquitously covered for all patients all the time on all insurance companies. It's not, unfortunately, lives would be much simpler, but that's not the case. So this is where some insurance information, inside information I have. So when we talk about New Hampshire Medicaid, patients and their providers have to demonstrate a need for a brand in New Hampshire Medicaid rules. And you guys may be familiar with this. They want a therapeutic failure of the generic before they'll approve the brand. So you may disagree with the literature that exists in saying that the generics are largely available and appropriate for your patients. You still have to put them on one. And you have to demonstrate that. And what they are looking for is change in blood levels, if you can measure that, change in a clinical presentation, which unfortunately means your patient may have an increased depressive state. They may have a new onset seizure. They may have we could go down the list. They may have some change in their otherwise normal health, and you have to demonstrate that, or they have to have an adverse reaction. So that means that they have to have some other of the three. They may not tolerate the generic based on the excipient ingredients. They have to have something documented in their literature, their medical record. For private insurers, if you wanted to get to that point about, so what can we do if we wanted a brand name? In New Hampshire, you have to say medically necessary for the patient to get the brand name product. Now, what does that mean for your patient? Even with the Medicaid services, we know that regardless, someone pays more for that. Generally, it's not the insurance company, but if it is, in the instance of private insurers, they pass that along to your patients. So it goes to the higher tier, or some patients, they will have co-insurance where they actually drop coverage from a tiered copay of like a $5 or a $10 copay when they cover 20%, the patient pays 80 or 50/50. There could be even further reductions with the accountable care organizations where you actually see a reduction in the money you receive from the government or from that entity relative to the care for that patient based on this.
Wow.
So there's a lot of changes. It's not just unfortunately as simple as saying I want my patient to be on this generic product or this brand name product. In New Hampshire, you do have a little bit more flexibility. Some of your colleagues down in Massachusetts, you may know that it's generic unless you specify otherwise. And if you put brand name, the patient doesn't have the choice to opt for it differently. The patient can't opt and say, I want a generic. In New Hampshire, they can also do that. You can write brand name. The patient can change their mind and say, I want the generic.
Because they don't want to pay.
Because they don't want to pay it. So, there are a lot of layers here. So how do you get around this? What do we do? And again, this is what Medicaid says for generic utilization. For their brand name approval, you have to have evidence of a trial in failed generics. Now, how do they verify this? Many of you probably know this, but they corroborate this by pharmacy claims. So they will look at the patient's Medicaid refills, and if your patient hasn't filled that consecutively within 180 days, even if they failed it, they'll deny it because they haven't been compliant with the therapy. Now, compliance could be one of the reasons why they had an adverse effect and they're not taking it anymore. But Medicaid wants to see that those patients are taking that over a 6-month period of time, and
So
if they
to
don't,
fail for 6 months.
yeah, they have to have failed it over 6 months.
And have taken it.
And have taken it.
And have taken it consistently.
And not get better, so we punish them.
Exactly.
Yeah.
So you tell
Actually, in California, it's 9 months, so
Yeah.
we do have some deal in New Hampshire.
So we're like doing experiments, making
Oh, yeah.
them ill.
Oh, yeah.
I see that a lot with our
Yeah,
reflux
body
kids.
control away.
Where they're going to have to fail
They have to go on
on
Xanten,
ranitidine.
or
They're going to go on
they-
ranitidine for 6 months and have esophageal erosion or whatever it may be, and lack of improvement, and until they'll approve whether it's the
Yeah.
solute
But
caps
then
or
the family
Prevacid, or
stops taking it because it doesn't work.
and if they don't fill it and it's not corroborated
Then
by
it won't be
6
part of
months,
it anyway.
Medicaid will deny
Yeah,
it.
they
won't
have
deny
denied
it.
Or
it.
has the right to deny it, I should say. They may not always, but they have the right to.
So
So-
if a child is on seizure medication, a brand name seizure medication, and then they go on generic, and
Mhm.
in a month they have a significant seizure, they have to stay on the generic
No,
longer?
in those cases, so there is another category where they say documentation of the brand is essential. So if you have a patient transitioning from a brand onto a generic, when a new generic may come in. So let's say you have a patient who's stable on Keppra XR. I don't know if you do, but let's say that. Keppra XR just had a generic approval this month. Next month, they go from Keppra XR to generic Keppra left tiracina extended release, and they have an onset in their seizure. You can use that as a documentation to get them back on the brand. Now, there is another caveat to that, and I'll mention that on the next slide, but essentially I have to say it now. They want that documented by a specialist. They want it documented for seizures, they want it from a neurologist. For depression, some of the others, they want them from a psychiatrist. So they unfortunately have even further restrictions where they kind of take that out of the hands of the primary providers.
So say that takes 6 months to get them.
If you have patients who are moving into this state or moving from a private insurer to a Medicaid program, which may be the case in some with people having kind of transitioned to jobs, they also want that the brand name is essential, and they will look at that as documentation from a specialist in that area, saying that they have to be on the brand name if they were stable on a brand name product, and now their new health insurance, Medicaid in this instance, prefers the generic. So they have a lot of restrictions in terms of shifting you towards the generics in many cases. And this is the kind of worrisome thing that I had alluded to. What I've been told is that as more generics become available for products, they're going to have much more stringent applications, so they may actually start holding much tighter to these dates of 180 days of therapy, where now they may give you, they don't have to hold it to 180, it's in the literature, but they could say after 2 months of therapy that a patient, if warrants, could override that, but they may actually start holding to this. Or they may go the way of standardizing with other states and saying we're going to do 9 months. So I don't have a good sense of what's going to happen, but what I'm hearing from people who do this, there may become much more stringent application of this.
So that puts the provider in an ethical dilemma, I guess. So say if you have the example of the child with GERD who has to be on 6 months of ranitidine, you have to basically tell the family they have to get refills, at least purchase the refills for 6 months.
Yeah, put you in a very awkward position.
But
in
don't
order
they
to-
sometimes approve it prior to 6 months?
They can't.
Because
And so
it doesn't
that's
seem
why I
like
said-
it always takes 6 months.
It's
No,
not-
what
it's
he,
not.
what he's saying though is it may get more stringent.
Yeah, it gets
They may start holding that line with 6 months. And from what I've heard is typically they'll say like a 2-month period, like a 60-day period is what kind of, if you can demonstrate that within 60 days the child isn't getting better,
Right.
then they will make exceptions. They may not necessarily do that for all patients. They may hold much more stringent guidelines for adults, which is children. They may hold all children to that 6-month
It
period. of
depends on
time.
the person you get on the phone.
It does, and it also very much depends on the person you get.
And your attitude. Very nice. Very, very
But you
nice.
also have people, so the person I talk to
Did you call every year?
is a psychiatric pharmacist. He has specialty of fellowship in psychiatry and has spent a lot of time, but he also reviews claims for anti-diabetic agents, antihypertensive agents. So you're not always getting someone in that specialty area. You're getting someone like me who could be giving you a thought on this, but could easily be doing something else on a different day that I'm not trained in. They're just looking at guidelines and looking at the literature.
Well, and I think it's important with children to remember that under EPSDT, there is an additional argument that you can put forward, that you demonstrate that actual treatment is not effective, that under
Yeah.
EPSDT, you can rationalize
And the pediatrics,
doing something sooner.
yeah, the pediatric patients do have kind of their own
Particularly with
subset
Medicaid,
guidelines.
that doesn't affect private insurance, but with Medicaid.
Yeah. And so looking at class-specific considerations, these are pretty much the same, but taking from Medicaid guidelines, new starts always require a trial of the generic, and that's their guideline. And that's what they put forth. The patient's currently controlled on the brand, so that was a question I would ask. They require medication for an anticonvulsant class if you're going to continue them on that once a generic becomes available, either documented by a neurologist or a psychiatrist. Now again, they can always subvert their own rules. They can say, we're going to approve this, but this is what they have published, and this is what the guidelines that they're asking their reviewers to go by. Same thing with ADD and ADHD medications. Most of these are coming out as generics. They're looking for either a neurology or a psychiatric request that the brand name product be covered when a generic exists. And this was an interesting point that I hadn't actually thought of, but one that my colleague had mentioned to me is that some providers are using Vyvanse in place of some of the other agents based on abuse potential, which there is a little bit of literature looking at Vyvanse having less abuse potential. And essentially that off-label type perspective is not in consideration for New Hampshire Medicaid. They don't care, for lack of a better term. They want to look at outcomes, control rates. And so for this instance, they are not going to approve Vyvanse without demonstrated failures of other generically available products and or brand name Adderall XR. So it's, they have a lot of restrictions in place. And again, they can't override them, but we may start to see them becoming much more stringent with that. So I've kind of just listed some forthcoming generics which may or may not be in your guys' practice. Some of these you may not be using at all. The Lulox CR I haven't seen many people use, but later this year we'll have generics in Malta. So that may be a benefit for some patients who want to use that in, but otherwise haven't been able to because of the cost or the restrictions around it. But we're not necessarily guaranteed to use or to have a Cymbalta generic available on New Hampshire Medicaid. Some places have moratoriums where they won't approve a generic for 6 months, where you have to continue with the brand. And the only other real forthcoming potentially related to this topic is Abilify, and that's not coming for 2015. So right now the ones that we have are the older agents, the risperidone, the olanzapine, and the quetiapine agents, which have their own issues relative to a whole host of issues.
Yeah, exactly.
So deciding between brand versus generic, and I apologize, I know I'm like a minute over, and I hate taking people's lunchtime and going over, so I'm sorry. Really, you have to determine, is there a measurable outcome that you can demonstrate? We talked about the antihypertensive medications. You can take someone's blood pressure. You can't really do serial EEG monitoring. You can't really monitor for some of these other conditions as easily. What's the adherence and affordability? There are some guidelines that publish making dose adjustments of the generic rather than switching between agents. But you still can't get over some of those issues relative to pharmacies interchanging generics. And what's the cost of the system? We may demonstrate that there's a decreased drug cost, but if there's increased cost in hospitalization, lost productivity, how much of that drug cost actually gets offset? And are you better using the brand name product? So we know that the FDA has policies that are effective based on the data they've produced relative to potency and purity, but that still doesn't take into consideration some of the other side effects or relative to lost work, lost productivity. I say hopefully these will be strengthened, but I can't guarantee that and when that will be and what horizon. Statistical versus clinical significance, what do we do with that data? How much of it really is applicable to our own patients? And as we know, the insurance companies are just going to become more stringent. So I feel like I'm ending on a down note. I'm sorry. But I necessarily don't have, I certainly don't have all the answers, but I hope this is more information than maybe you had when you walked in the door. Maybe it's bad information, but at least it's more information. And I apologize, I don't have this, I noticed this morning when I was going through my slides, I didn't include my contact information, and I don't have updated business cards with me. So if anyone wants to either get a hold of me, telephone or email, I will leave this here. You can certainly, Judy has my email as well, so if you have colleagues who you think would want a copy of the slides, I know I sent them to Judy, but I'm happy to kind of reach out if you guys need anything else. I don't know what I can help with, but I'm always willing to try. So thank you guys, I apologize
Thank you
for the
very
couple
much.
minutes over. So
Thank you
thank you.
very much.